Thank you for tuning in to this brief video where we will be using near-infrared spectroscopic imaging to look beyond the epidermis and explore the nutritive hemodynamics in the microvascular beds of the dermis. My name is Mike Sowa. I'm Chief Science Officer with Kent Imaging, and I'll be joined later in this presentation by Dr. Brian Lepow. He'll go in and provide his clinical insights and experiences with this technology. We use near-infrared light or spectroscopy to measure the hemoglobin oxygen saturation in blood. That is not new. Pulse oximetry, for example, measures the oxygen saturation, but it is the hemoglobin oxygen saturation in the larger conduit arteries. The oxygen saturation we provide is more representative of the hemoglobin oxygen saturation in the smaller vessels, the arterioles, the venules, and the capillary beds. These are the vascular beds where gas exchange occurs with the cells, and thus we provide an indication of the oxygen delivery and utilization in the local tissue environment as opposed to the larger vessels. This is potentially a useful tool to assess vascular disease at the microvascular level. We rely on near-infrared light to provide a measure of hemoglobin oxygen saturation because near-infrared light more readily passes through the epidermis. This is especially true when the epidermis has a high melanin content. In those situations, near-infrared light can still sample the vascular beds of the underlying dermis. We provide an image of the hemoglobin oxygen saturation of the tissue, and thus enabling you to detect or confirm local oxygen deficits in the dermis. We bundled these capabilities into a handheld imaging system that we call Snapshot NIR. It operates like a normal digital camera, requires very little training to get high-quality images. But in addition to the regular color image you get with a digital camera, we provide a pixel-matched hemoglobin oxygen saturation image. This combination of images blends both visual assessment with a hemodynamic overview of the tissue. This added information hopefully gives you greater insight into the status of disease or the healing in your patient. This wraps up my introduction to the technology, and I'll now hand the rest of the presentation over to Dr. Lepow. Thank you.
Thank you, Mike, and thank you to all who are tuning in today virtually from the comforts of your own home and or office. I'm going to pick up where Mike left off and talk a little bit about the clinical applications for the Kent imaging snapshot device. A brief overview of wound and oxygenation. Wounds heal at a quicker rate when there's good blood flow, as we know, and adequate oxygen availability to the wound site as well as the surrounding tissue. Wound is considered a chronic wound once it fails to heal within a predictable healing range, generally at about 4 weeks. Failure of wound healing may result in amputation of the limb, and we know the rate of amputation in the diabetic population is quite high. Chronic wounds lead to disabilities and high morbidity and mortality rates. Current oxygenation perfusion is tested with the use of SPP, which some of us know is no longer available on the market. Unfortunately, it's a time-consuming test. With the Kent imaging snapshot, we're able to cut down on time of use and drastically produce instant oxygenation images. The Kent imaging snapshot, some of the advantages include a non-invasive type exam, eliminating the use and need for injectable dyes. There's no real need for contact with the wound site and diminishes that risk for the patient. It's a portable device, really can be taken anywhere, thrown in your backpack, taken from the office to the operating room to the wound care center, so it's quite portable. Fast oxygen saturation images processed within a few minutes, which is great. So it's very easy to process, not a lot of downtime waiting for the images to upload and for you to get a good result. And the overall aim is to capture and study the treatment journey of the wound, get a good understanding of the changes in the wound and tissue oxygenation levels throughout the entire treatment process of the wound. Tracking tissue oxygenation in chronic non-healing wounds with the use of adjunct therapy. So I'm going to talk to you about a couple adjunct therapies that we've utilized in our clinic setting and how the Kent imaging snapshot helped us evaluate those wounds. In our first study, we had a really handy device that some of y'all may be familiar with, topical oxygen therapy. This was continuous diffuse oxygen therapy, and this is a randomized controlled trial study currently undergoing in process here at Baylor. In this particular study, patients included diabetic foot ulcers, mid to moderate vascular insufficiency, and minor amputation rates surgically closed. So this, unlike some of the other topical oxygen studies, this is on closed wound environments. Intervention group is 4 weeks. Innovative dressing was applied for 4 weeks. You have the controls and the outcomes were then tracked. So here in your first case study, you could see here both in the pre-imaging and the post-imaging. On the left-hand side, you have the pre-imaging study along a transmetatarsal amputation site. There at the initial closure, you see the O2 saturation is 49%. After the use of the continuous diffuse oxygen therapy device, it is now up to 60%. And you could see that both from the SAT O2 readings, as well as from the color image that's displayed on the bottom screens here. In our second case here, also great evaluation of the amputation site here. A second digit amputation was performed. Original SaO2 rate was 18%, thus with the use of the continuous oxygenation device up to 32%. And that's well captured here, both in the clinical setting and the picture above, as well as the image on below, which is an image using the imaging snapshot device. You can see the increase in oxygenation to the tissue, not only at the wound bed, but around the periphery of the wound site. Second study design I'm going to talk about was a was a randomized controlled trial with the use of electrical stimulation. This is another adjunctive therapy that we're testing here for advancing and increasing wound healing. This particular study was a 4-week double-blinded randomized controlled trial. Included 38 participants with diabetic foot ulcerations and mild vascular deficiency. We have our intervention group and control group. Basically, they were utilizing an eStim device as per the picture here, up to 4 weeks on a daily basis. And then we tracked their oxygenasis changes both with SPP, visual inspection, as well as the KIN imaging snapshot device. So in the intervention group here, this is where things are really interesting to see. Wound size and StO2 were tracked. Here on the left, you can see the baseline, the size of the wound, and then the original SAT oxygenation at 52%. After 4 weeks, you can see that SAT oxygenation up to 85%, which is quite significant. Increase in wound healing. Overall, a 92% reduction in area of the wound site, as well as a 34% increase in the StO2 reading, which is quite impressive here. Really great images to capture not only just the visual inspection, but also give you a good readout on what O2 saturation looks like to the surrounding periphery of the wound site. Just for comparison, this was the control group. So in this particular study, patients were assigned either to an active device and or a sham device. So the control group would be the sham device, a non-active device. And here you can see a chronic calcaneal ulceration here. I'm sorry, a chronic ulceration of the distal transmetatarsal amputation site, subfirst met, very common area for breakdown at transmets. And here on the baseline, you can see the SAT oxygenation was 87%, and then thus at 4 weeks was at 84%. So this just kind of demonstrates that there really wasn't much change, which kind of helps us to understand both the intervention and control group and what all is happening. So there's 0% area reduction and a less negative 3% SaO2 decrease. And so this, again, just comparing to the intervention group, shows that utilizing this device, you do capture pretty significant findings when controlled when used in comparison to a control group in this particular study. Other practical applications for the device include the following. The snapshot device provides instant visualizations for oxygen saturation of surgical wound sites. This is great for both pre and post debridement measurements and get a good evaluation of the wound bed. Again, you know, it's not what you can't see with the eye itself, but this also helps to determine sort of the peripheral, the surrounding tissue, and what oxygenation looks like. I've been familiar with a lot of these devices over the years, and I think that certainly these images really speak volumes versus just telling somebody, oh, your ABI is this number or your SPP was this number. I think if you can really produce an image like this, people can see it, they can visualize it, better conceptualize why things are the way they are, and why further debridement and or plus or minus amputation may be necessary. The device is also great to give accurate images both on the wound and surrounding tissues, as we discussed here. You can see prior second digit amputation site with a large wound site that was debrided and has a split thickness skin graft. You can see the comparison to the clinical image and the KIN imaging snapshot image here at the where the site of the granular wound base is. 71% oxygenation around the periphery of the wound site. You see the split thickness skin graft, which is well incorporated. It can also be used for assessing oxygenation levels around the wound. This data is very helpful to predict healing processing time. We've talked about this before as well, and here you can see both on the left-hand side and the right-hand side, the clinical image and the KIN imaging snapshot device images, both demonstrating around the periphery of the wound there is some hyperemia, however, increase in oxygenation around the periphery, which does show a positive indicator for the ability for that wound to continue to progress towards healing without the need of any adjunctive therapies. just some concluding thoughts. I know we breezed through this and happy to answer any questions that may come about, but just some concluding thoughts about the technology. I think technologies are great. And as we've come to learn, some of the current things that we're using to look at perfusion, look at oxygenation are no longer available on the market anymore. So we have to kind of start thinking about the future and how we're going to better assess these patients in an efficient manner. And so I think the aim of this device is to capture, monitor, and study the treatment of the process throughout its entire continuum, to get a general understanding of the changes in oxygen levels throughout the entire treatment of the process. This design of the device is great. It's sleek, lightweight, handheld, allows it to be transportable, which I think is really important for most doctors out there. A lot of us have multiple practices, go to different sites of visits. And so to be able to take this device from one place to the next will allow you to continue that continuum of care for your patients without having the burden of porting around a large device. The device is handheld. It can be used pretty much anywhere, as I previously discussed. And then the whole concept is that we can see beyond the epidermis to assess tissue viability and the potential of a wound to heal. So we're trying to think of what's going to be next, what's on the horizon, what are things that we can do that are not only sort of eloquent type devices, but also things that have levels of reimbursement, which I know the device has, and we won't discuss much about this in this lecture, but that's something that is on the horizon. The company's been diligent about working on reimbursement tools for the device. And plus you get these real-time images, which are captured within a few seconds. And I think really speak volumes when you're having a conversation with the patients and other providers in terms of discussion with the patient and their overall care and plan for wound healing. So this kind of concludes my discussion today. Thank you very much for your time. If you have any additional questions, those can be directed to myself and or to the kit imaging people, and they'll get them to me, and we'll happy to answer your questions as needed. Thank you very much for your time.